The conference would not be possible without our wonderful sponsors. And we'd like to acknowledge the sponsors now at this time.
Good morning, everyone. Can you hear me okay? Fantastic. It's good to be home. I find myself standing before you this morning a wee bit emotional. It's the first time I've been back across the Canadian border in almost 2 years now. And I cannot think of a place I'd rather be this morning than with the people who inspire me most. And those are all of you, people living with Parkinson's disease and your families. Some of you may remember me from my time here a while back. It's been almost 7 years now, I think, since I left and have taken up my position in Chicago. And so I come to you today from Northwestern University. I have a tiny, I guess, bit of news, provided you all promise not to share it beyond this room. So can I hold you to a secret? Like the entire room, can I hold you to a secret? Okay. I'm coming home. So I will be back here next year. So my research program has always been straddled between both countries. Some of you may know that, others may not. So I've always maintained a lab here in Canada. I work closely with groups in Toronto, as well as with the Ontario Neurodegenerative Disease Research Initiative, for those of you who have been involved in that study. So I'm one of the investigators on that initiative. So I've been back and forth for a long time, but gosh, it'll be good to be home. And so I'm excited to kind of have the chance to rejoin you all here in the next year. So today I'm going to take a few minutes. I've got a couple of agenda items I'm going to get across. So once we get started, I'm going to share those with you. If you need me to slow down, someone wave a hand. You know I get very excited when I talk, and so if I speed up, make sure you tell me to slow down. If I move around and get disconnected from the microphone, make sure and wave at me or yell at me or jump up and down or do something that lets me know that you can't hear me. I have to thank those people who fund my research, so that includes Parkinson's Canada as well as the National Institutes of Health in the US. And our work is also funded by the Ontario Brain Institute right here in Ontario. Okay, so a little bit of a quiz. I'm a professor. I have to quiz you a little bit. So first kind of question today, raise your hand so we'll keep the movement going from our fabulous choir presentation. Raise your hand if you have difficulty speaking, your voice is quiet, your sounds don't always come out clearly, so kind of get both hands up in the air. Fantastic, you're all going, you're a speech therapist and you don't know this? Of course I know this. How many people in this room raise your hands if you have difficulty finding words? Yeah, getting your thoughts together. You don't get to count, Dr. Fasano. How many of you have difficulty following a conversation, not just getting your words out, but when a conversation's going by really quickly, keeping track of all the turns and catching back up when you want to? Yeah. And how many of you on occasion actually pull back and choose not to go to an event or pull into the corner of a room because communicating is just too tough? A few. So we communicate with our entire body, right? We communicate with our facial expressions, our mouth, we communicate by listening, our gestures, and Parkinson's disease is a whole body condition. There is not a single channel of communication that Parkinson's disease does not affect, and yet we find ourselves the majority of time focusing on things just like, is my voice loud enough? Are my sounds clear enough? And so part of what I'm going to focus on today, I'm kind of laying the groundwork of what is the hallmark of my research, which is really thinking about communication as a whole body entity for people with Parkinson's disease and how communication then integrates and permeates into every aspect of your life. And as you go throughout the talk today, you're going to see a little bit of this bias in my work. But we even know that Parkinson's disease, beyond the obvious of affecting facial expressions and speech and voice, it also affects hearing. So we have a little bit of new research that tells us that people with Parkinson's disease are actually at slightly increased risk for developing hearing loss compared to others of similar age. We don't understand why this is just yet, but we now add it to the layers of communication challenges that can be experienced by people with Parkinson's. So we know that Parkinson's disease affects motor symptoms and non-motor symptoms, and now we're starting to push this into realms of thinking about how does it affect actually something we call social communication or social cognition. When I first went back to do my PhD, and some of you who know me know this story, it's because I had been working in a movement disorder center of excellence for a lot of my clinical career. In fact, I worked in Dr. Jog's clinic for some time. And for me, the problems that I was hearing people talking about relative to their Parkinson's disease were not the things that my treatments targeted. And yet we weren't talking about those characteristics. We weren't talking about word retrieval issues. We weren't talking about challenges following conversations. We weren't talking about difficulty reading the emotions of others, not just producing them, but actually being able to say, are you being sarcastic? Are you being funny? I'm not sure I'm interpreting that. We weren't talking about any of those things, and when we talked about them, they were always in the context of, oh, these are advanced Parkinson's disease symptoms that are associated with dementia. And that was scary for people, right? Really scary. But I wasn't always hearing it in that context, and so since I left you, the last little bit, we've been trying to deconstruct some of these concepts, and I'll share some of that research with you today. But one of the things that we now know is this whole list of symptoms that I have here that are both motor-based, like quiet voice, maybe not able to use your gestures or your hand movements or your body language as spontaneously as you would like, hoarse voice, those are all known symptoms. But we also know that that tip of the tongue phenomenon, that trouble finding words, the ability to perceive the emotions and the intentions of others in conversation, as well as the ability to maintain your train of thought. Those are all we think now pretty, dare I say, normal. There's not really anything normal about Parkinson's disease, but dare I say somewhat normal symptoms of Parkinson's disease. And they can happen early in the disease, and they can happen even in the absence of substantial cognitive impairment that might rise to the level of being a mild cognitive impairment or dementia. So we're starting to change our perspective here. When I first started this work, motor speech aspects of Parkinson's disease and cognitive aspects of Parkinson's disease were two separate bins that we talked about. And now we actually know they overlap quite a bit. They overlap in such a way that we actually know being able to kind of what we think about as attentional control, so the brain's ability to shift its focus across multiple kind of areas that it's having to kind of attend to, actually affects whether or not you produce a sound correctly. It's not just purely motor. Cognition layers in with these motor aspects in every way, shape, or form, in the same way that we now know cognition overlaps with walking and gait and movement. And this is exciting for me. I just got asked, and this is not, it sounds like brag book. I'm not brag booking, I promise. I'm not doing that. But I do want to share with you this exciting space, which is for the first time I was asked to write a neurology textbook chapter that'll come out this year that is actually focused on the cognitive and motor aspects of speech production and speech changes in Parkinson's disease. For the first time, it's a normalization of this research for neurologists and other healthcare providers who can say, those are now just kind of what we expect to see. We need to be talking about more in the clinic than just voice issues or just speech clarity issues. We need to be having conversations with our patients that help them to understand this is part of the disease and helping us to push closer toward treatments that support. So when I was asked to write that chapter, we just finished it and got it off to the publisher. It was like one of those, cry moments for me. I do those on occasion. It's those moments where you realize that your life's work has kind of come around, and that thing I fought so hard for, the voices of all of you that took me back to quit my job and go back and do a PhD that set me on that journey, your voice comes through in that chapter. Because it's now this kind of recognition of this kind of mainstream component of the complexity, the absolute complexity of communication challenges for people living with Parkinson's disease. So we know that you all are sensitive to these changes, right? We've known that for a while. You have been telling us that it's not just my speech issues. There's all these other behaviors that I'm experiencing and changes that I'm experiencing. And you know that they are part of the communication path that you're on, the challenges that you're having, as well as they're part of your progression. So this is really just kind of bringing home what you've already known. One of the areas this is starting to change, though, is people are starting to kind of link up what are these challenges and how do they link to concepts like social isolation, withdrawing, dehumanization, and stigmatization for people living with Parkinson's disease. So we're now starting to say, okay, these aren't just issues, but how is it actually impacting them on an everyday life? There's a lovely review article written by Dr. McDonald, who's here in this city. So her group recently wrote a really nice article on this. But it's that reminder that when we are providing services for, caring for, working with people who have Parkinson's disease, we do need to think about not just how they see the world around them, but how does the world see them in the face of changes in facial expression, changes in ability to speak, changes in ability to interact with others. We know this can also, and we've got a little bit of research on this front showing it also affects the care partners. So if your person with Parkinson's disease is not as comfortable going out, not as comfortable engaging with others, it can also be isolating for the care partner. So I want to acknowledge that. I want to acknowledge that this is not just a person with Parkinson's disease phenomenon, that this actually does affect the whole family. And while we won't be able to, I don't have time, you could have me here all day, and trust me, I will find a way to fill the space. While I won't necessarily be able to get into all of it today, the treatment programs that my lab designs and the treatment programs that we put into place are actually not just for the person with Parkinson's disease, but we treat in the context of the full family. So we do what are called dyad-based interventions, meaning it's the person with Parkinson's disease and their communication partner and their family members who come in and do treatment together. And we do that with this recognition that A, partners are important to intervention, and that B, communication challenges actually affect the whole family system. So while 90% of people experience speech changes, our understanding of what makes this so complex is often not as clear as we would like it to be for the health professionals that are working with people who have PD. And we know this a bit. This is from a paper that we did, just released earlier this year. And we looked at 20 Parkinson's disease movement disorder care centers around the world. So these were all expert care centers from Italy, several sites in the UK, sites in the US, sites in Canada. And we actually looked at 5,020 records from those centers. And what you see here on the axis of the graph that goes up and down, so the vertical axis is a percentage, and what you see on the flat horizontal side are 3 different therapies: speech language pathology, that's SLP, physiotherapy, that's PT, and occupational therapy, that's OT. And what you have in the dark gray bar there are the people with Parkinson's disease who are early stage disease, and then moderate disease in the middle, and then the bar on the far right of each one of those clusters is advanced disease. So remember what I just said to you, 90% of people with Parkinson's disease have changes in speech and communication, and at any point in time in the disease, less than 4% of them around the world in expert care centers are actually getting referred to speech language therapy services. That's just fact. 90% have difficulty. Less than 4% across each of the individual disease stages are getting referred. When you compare that to physiotherapy, it tells you where physicians think the problem is. And I'm not bashing physicians, I'm not. This is not physician bashing at all. But it's our awareness of where we think the symptoms of Parkinson's disease are particularly problematic, and sometimes our challenges in considering all of the domains. And when we look at this further, one of the things that we also see is that it doesn't change very much across severity. So whether you're talking about being in early stage, moderate stage, or advanced stages of the disease, your likelihood of getting referred to a speech-language pathologist is about the same. So we know there's this underutilization piece, and the easiest answer is to say, oh gosh, there's just not enough speech-language pathologists out there, but we also know that's not fully accurate. We know there's not enough skilled clinicians out there who are aware of Parkinson's disease, because this isn't just a problem with the physicians. This is a problem with when you get referred to a speech-language pathologist for services and they assess your swallowing. They might take a look at your voice, but they don't really ask questions about the breadth of challenges that you might be experiencing. So that can be frustrating, and it can lead physicians to say, gosh, every time I send my patient to the speech-language pathologist, I know they have issues, but they're just going to assess their swallowing. That's not really what they need. Right? So this is not just a problem within our neurology community, this is a problem within the rehab community generally around knowing what are the scope and scale of the challenges in Parkinson's disease. There's a study by Fullard and colleagues who actually looked it was a study done in the US looking at the number of referrals made to speech-language pathologists and other rehab services, and they also looked at the density of rehab professionals living in different areas, and very similar kind of to the data that we see in Canada. And they found it was not the lack of density of professionals that made the difference. It was the lack of knowledgeable professionals that made the difference. We also know that there's this lack of kind of well-defined care pathways for people with Parkinson's disease. We've tried to take care of some of that on the Canadian side, but it does not exist around the world. And lastly, we know there are biases in referrals. One of the things that we saw in the data set that we looked at, which was interesting, was the greatest thing that drove, and we looked at a bunch of factors, how well people were walking, whether or not they had swallowing issues. We looked at all these clinical factors in our data. The one thing that was the greatest predictor of whether or not someone got a referral to a rehab service was whether or not the care partner asked for it. It had nothing to do with the walking scores of the person with PD. It had nothing to do with their swallowing. It had nothing to do with their cognitive abilities, any of the measures that were collected as a part of the study. It was just whether or not the care partner asked for it. So hence, because I don't believe in a can't-do attitude, you might gather that by now, I'm a can-do person. My goal today is to empower you. I want you to walk away today feeling as passionately about this as I do. I want you to walk away today knowing what therapies are available to you. I want you to walk away from today with this knowledge and understanding that communication challenges are complex in Parkinson's disease, and you are not alone, and you have the right to push back and ask for help. And I want the care partners in the room to remember that you need to ask, or direct care providers to your person with Parkinson's disease to say, ask them what they need and want. Right? Empower them, empower their voice. We had a fantastic choir presentation, and I mean it was fantastic. I said I get a little teary. I got a little teary. It was wonderful. That's empowering. We want to take that same empowerment of voice and have you advocate for yourself. So here's what I'm going to do today. I'm going to focus a little bit on some of the current PD treatments and communication changes. I'm going to give you an idea about some helpful tips and hints that you might be able to take to your own clinician to help you. I am going to focus on the behavioral treatments today for speech and communication changes, but if you have questions later on in the day around the impact of things like medication or deep brain stimulation surgeries or things like transcranial stimulation, I'm happy to address those, but I'm not going to spend too much time on them during the talk today. So after I finish kind of going over these therapy pieces, then the other thing I want to do with you today is I want to share some hope and some excitement with you. And I'm going to share some hope and excitement by sharing with you some of the research that we've been doing in our lab, some studies that are coming to Ontario and are already here, that are really pushing the window of how we think about speech, communication, and cognition changes in Parkinson's disease and how they interact with a whole body perspective. And I'm going to share some of that with you. So 5 years ago, if you had asked me to do this talk, the only real treatment program that we talked about to any substantial degree was the Lee Silverman Voice Treatment Program. Most of you have probably heard of it. It's an intensive kind of voice therapy program for people with Parkinson's disease that people attend over the course of a month, typically 4 sessions a week. And it's intended to strengthen the respiratory muscles, similar to some of the exercises that you saw as part of the vocal music therapy session that we saw earlier. But then tying those in specifically to speech versus to singing. And it operates on the premise of repetitive practice will strengthen muscles. So it's been around for a very long time, almost 2 decades. There's lots of evidence that it works. The challenge with that evidence is that it doesn't always, the therapy itself sometimes translates better into everyday talking than, for some people, more so than it does others. But for the last 20 years, it is the only therapy we've been talking about, the only therapy. And now we're starting to see come into the Parkinson space, and this is really exciting for me. The evidence is still low on some of these therapies, so I'm not going to mislead you. The evidence is still early. But for the first time over the last 5 to 6 years, we're actually starting to see new therapies being developed for people with Parkinson's disease and their voice and speech problems. And this is wonderful, right? Because they're taking slightly different tactics. So this kind of speak out loud crowd program is probably the newest kid on the block relative to therapies. It's a lot like the Lee Silverman approach in that there's a lot of exercise component to it. There's a lot of strengthening your voice and kind of repetitive talking practice. One of the things that it does do differently, though, is it takes on the principles of some principles that have been coming out of gait and walking therapy to kind of challenge people to talk under different cognitive conditions. So one of the things that has kind of been coming out in the physical therapy and the physiotherapy literature is this thought that if you're walking while doing a cognitive task, if you're doing what we call this dual tasking kind of approach, it might help both your walking and also help your cognitive focus while you're walking. And so speak out and loud crowd is a way of trying to adopt some of those principles that we're seeing work in the physical therapy space to speech therapy, and is actually having people talk under different cognitive loads or different kind of demands of difficulty. So it's one of the ways that it's different. The other way that it is different is it doesn't focus just on being loud, which is the central focus of the Lee Silverman approach, which is why it falls short a bit of the actual communication needs of some people. But it also focuses on making your speech clear. So this kind of notion of over-articulating or enunciating clearly. So it combines both vocal approaches as well as what they call speaking intentionally. So the evidence is still early here, but there's reason to believe that it might work pretty well for some people with Parkinson's disease. Like with all of these interventions, the challenge is that they haven't been tested on people with more advanced symptoms or people who actually have cognitive changes as a part of their disease. So these therapies have really been best tested or most tested on people with early stage disease. But the excitement is that there's actually something else that's available. The other benefit to kind of the speak out and loud crowd program is it actually has a group-based component, which works out really well for some community-based agencies to run, unlike LSVT. And while it requires training, it doesn't have the rigid kind of aspect of LSVT that means that you have very few clinicians who can actually get trained in how to do it. So here, it's just simply a more accessible intervention. Singing and vocal choral practice, and the group earlier kind of really gave us an example of how this helps to work on respiratory systems and breathing muscles are really critical for speech. And we actually, again, have early stage, not a lot of robust trials yet, but there are early stage studies that show that kind of these breathing support singing exercises can help people to feel less fatigued when talking and also help them to get longer sentences out. What we're really lacking in the field, and as a scientist I have to kind of call us out on this, is that we have very few high-quality trials and we have very few studies that look head-to-head which of these interventions is best against another. And that's really problematic for people with PD. So here's advocacy point number 1. Write your government, advocate to people who fund research, and tell them you need more comparative trials. We know, for example, and we're continuing to do research, for example, in types of medications or types of surgical approaches or types of stimulator settings, types of different other components of therapies that work or don't work better, depending on the individual characteristics of a person living with Parkinson's disease. We're trying to get at that. But on this behavioral piece side, not very much. So that still leaves people with Parkinson's disease having to do this trial and error approach. I'm going to try therapy number 1. If it doesn't work, I'm going to try therapy number 2. That's a waste of your time and a waste of funding. So advocacy point number 1, let's get more comparative trials in place. There's one of these that we currently have just completed with colleagues at UMass Amherst that'll start giving some of this information. And so hopefully next time I'm here, I'll be able to share those results with you. But there is another new treatment on the block here. So how many of you have heard of the SpeechVIVE device? Okay, so we're going to talk about this one. The SpeechVIVE device is the one and only device that has really been designed for people with cognitive impairment who have Parkinson's disease, because it doesn't require much behavioral engagement at all. It's a device that looks like a hearing aid. You wear it. It operates on the principle of something that's called the lumbar effect. It measures how loud your voice is. When your voice drops below a certain level, it plays what sounds like a cocktail party noise. What that does is activates a response that's called the lumbar response, and your voice immediately lifts up to try to talk over the background noise. Now, one of the things we know about Parkinson's disease, your voice may be quiet, but the lumbar response, you still have. Your voice may not be able to get as loud as someone who doesn't have Parkinson's disease, but you can get your voice above the background noise. So for people who have cognitive impairments in particular, where thinking about being loud while trying to plan what you want to say, while trying to walk through a room can be really, really difficult. This device just takes care of the issue. Your voice gets quiet, it plays the babble, you talk above it. It's actually incorporated in the context of a therapy as well, where you wear it for 1 to 2 hours a day at home every day. You read aloud from the newspaper, you engage in conversations with your family members, and when you do that over the course of 30 days, like our other therapies, it actually strengthens the muscles that you use for speech, including your breathing muscles, and including your laryngeal muscles, which are needed to open and close in order to produce your speech sounds. So this device is actually now on the US side is fully funded through the VA and funded through other agencies. And I know it's actually in the process of trying to work through its funding approvals here in Canada as well. So this is something to kind of keep an eye out for people who in particular have had challenges kind of being resistant in terms of vocal loudness changes in the context of PD. So here's what we know from some of this converging evidence. We know that if we train specific muscle groups, they get better. We know that intensity matters, and this is the hard part, folks, because it takes work. It's not just kind of, you can't go to therapy once a day and you cannot do your home practice. The intensity, just like with any other exercise program here, matters, and being consistent with your exercise matters. We know from animal models, we don't yet have a lot of human research, but some of the animal model research tells us that if we work these muscles early in the disease, we might slow down or slow the progression of voice and speech changes in Parkinson's disease, but this is still very, very early research. There's some replication in the animal models, but it's not really in terms of our ability to make this kind of clinical standard yet. But in general, we're starting to recommend that people go to therapy earlier, even before their speech problems are so bad that they can't communicate. And we know that especially changing loudness, if we do that in an intensive way, with these high-intensity exercise programs, that it can actually change how the brain is kind of connected. When we think about areas of the brain that aren't functioning the same as they did before Parkinson's disease, we can increase activation and increase connectivity between regions of the brain that are used for talking, but in the context of these very, very high-intensity therapies. So the issue is that just increasing your volume isn't enough. And I started off kind of the initial part of my talk today with that, is that these problems are much more complex. So some of the research that we do was trying to get at this. So this is early research that we did, and we've continued to do these studies where we basically become a fly on the wall in your house. We install cameras that are very, very low, kind of visibility, so you don't really see them. We have special recording devices that you can't see. We become spies, if you like. And we've actually recorded thousands of hours of conversations between people with Parkinson's disease and their family members. One of the things we discovered is that when conversations break down, so when the messages don't get across, and I don't know about you, but in my house this actually happens a lot anyway. But in a house in people with Parkinson's disease, we know that those moments of breaking down in conversations happen about 4 times more than in a house where there is not someone who lives who has Parkinson's. But we know that almost 2/3 of those breakdowns happen for reasons completely unrelated to voice loudness or speech clarity. There's a lot else going on in these conversation breakdowns. And they happen because people use incorrect words. They happen because of facial expressions being flat. They happen in part because of some of the behaviors of care partners. We're going to talk about that. It's not just the person with Parkinson's disease. So this is a little bit of a graph from some of the work that we've done. When we talk about a conversation breaking down, we call that a conversation breakdown. And then we go through these data and we look at a very granular way as to what caused that conversation breakdown. Was it that someone mispronounced a word? Was it that their voice wasn't loud enough? And we call those trouble sources. And so what you see again on that vertical axis are the mean percentage of all trouble sources that can be attributed to reasons that are going across the horizontal axis. What you have in purple are the care partners. That's when it was their fault that the conversation broke down. And so I hear the giggles in the room. And what you have in orange is the person with PD. So your first observation should be, it's not just the person with PD. And your second observation should be that there's a whole lot going on in these conversations, right? So motoric reasons are reasons because the speech sound wasn't clear or the voice was too quiet. Language, form, and content include reasons related to someone using the wrong word or actually switching around the words in a sentence so that the sentence doesn't make sense. So one example we have from this is screw gone down, not right. And the gentleman was trying to say, I can't get the screw to go in, right? But in that moment, the words came out all jumbled. Discourse and topic management means most often that the turns are kind of out of sync. So do you ever have this experience where you're talking to the person with Parkinson's disease and they might be delayed in their response, and so you jump in and then they jump in and then all of a sudden no one can hear or understand each other? That's a lot of what these moments are. And almost all of those are driven by the care partner. Because the care partner doesn't wait through the person with Parkinson's disease, and I see heads nodding and giggles, right? This is the moment where typically people with PD pat someone on the back and say, it's not just me. I told you. And it's not just you saying talk louder. That's not all the issue here. And then environmental factors are things like lawnmowers going on in the background, right? And then unattributed are ones that we just can't kind of put into a bin. So both the person with PD and their family care partners contribute to these conversation breakdowns, and they do so in different ways. These data were the data that drove us to the point to say, doing interventions with just the person with Parkinson's disease doesn't make sense, right? If we're going to do therapy, we need to do therapy with everyone who's living in the household so that everybody knows how to help support these moments of communication difficulty. So I'm going to slide through a couple of helpful hint slides here. I'll make sure that you have these, so if you want them, and I'm happy to kind of give them to Mandy, and Mandy can kind of distribute them out. I am going to go through these pretty quickly because I want to save some time here at the end to talk about some exciting studies that are coming your way, and real opportunities for you to contribute to what we understand and know about speech and communication changes in PD. But I do want to touch on a few of these. The first is to always set yourself up for success. So these are some of the principles that we teach when we work with families and people with Parkinson's. And that includes making sure that when you want to have an important conversation, the TV is off, the kitchen sink is off, the radio is off, preferably the lawnmower isn't going on in the background. And you want to think about choosing the time of day carefully to have these conversations. I was giving a program with the World Parkinson's Congress 2 weeks ago now, with one of our Parkinson's family who lives actually out in Vancouver in BC. And so the wife of that person and I were sitting on the same speaker panel. And the first thing she said, he was relatively a younger person with Parkinson's disease, so late 40s when he got the diagnosis. And the first thing she says, in their house, there are no important conversations that happen after 5 o'clock. It's just a rule. After 5 o'clock is not a good time of day for him. In your own household, there will be times of day that are better or worse. Maybe that's no conversations before 10. Maybe that's no conversations after 7. But it is A-OK for you and your partner to negotiate. There are times of day that we're just not going to be able to have these meaty conversations. Do not ask me about 3 estimates to have the roof changed at 8 o'clock at night when I'm exhausted. It's not going to go well. So thinking about how you and your own family can kind of set up these rules or structure for when meaningful conversations can happen is important. We also remind people to check in with their emotions. You want to constantly monitor, and this is where the burden does fall on the person who does not have Parkinson's disease. It is your job to kind of monitor the context. Does it look like someone's having difficulty processing? Do they have a quizzical look on their face? But if you're the person with Parkinson's disease, it's also important for you to give a signal, which says, hey, I'm not following this. Can you slow down? I didn't get you. Can you repeat that? I need more time to get my thoughts together. Give me a minute. Right? We're not mind readers. And so it is important for you, we teach families how to negotiate some of these strategies. This isn't rocket science, folks. It's not. I didn't need a PhD to kind of be able to come up with these strategies. Teaching and training them, getting people to use them in their everyday life, that takes a little bit of work. But the ideas themselves are very common sense, right? And so then sitting down to kind of talk about in your family, how do you want to let me know when we're at family dinner and everyone's there and you're getting lost in the conversation and you need it to slow down? What's our signal? How can I stop the conversation to give you more room, more time, right? And these are all things that you can kind of negotiate in your own home. We think about this as negotiating preferences. I'm A-OK with people talking for the person who has Parkinson's disease only if that person's given you permission. It is not okay to fill in their words or speak for them unless you've talked about it beforehand. That's not okay, because it takes away their agency and their voice. When you're at the doctor's office and the physician is asking you about your person's symptoms, you can turn your body language and say, I don't know, ask John. I understand that you want to talk to me, and I'll fill in where he's having trouble. I'll say, John, do you want me to fill in here about that episode you had last week? But you can, as the care partner, change the direction of the conversation so it encourages others to talk to the person with Parkinson's disease. And why is that important? It's important for this reason. The masking of facial expressions that we see in Parkinson's disease, we are, as human communicators, we are genetically hardwired to read facial expressions to indicate people's interest in their engagement. We see them as human through their facial features. when those are flattened in Parkinson's disease, there's a real psychological response on the part of the listener, no matter how much they know the disease, and especially if they don't know the disease, to think that someone is not engaged, and we instinctively turn our attention to someone who is. This is not someone's willful decision to ignore the person with Parkinson's disease. This is them acting on their own hardwiredness around what is in human communication. So we as the partners, we as the ramps, we as the facilitators to help keep people with Parkinson's disease engaged in their lives have to go out of our way. We have to go out of our way to facilitate and make sure that direction is attended to them. You want to make sure that you're communicating because we know that it's not just conveying emotions, but also receiving emotions that can be impaired in people with Parkinson's disease. We've actually done some of this research, and we have an NIH grant that's going in 10 days to kind of continue this research. But when we show people with Parkinson's disease movies of conversations, and the speakers are conveying things like humor or sarcasm or anger or sadness, so we have actors intentionally kind of queued up to convey these different emotions. One of the things that we see is that people with Parkinson's disease make errors in judging those emotions, and this is early in disease. This is not advanced disease. This is not in the context of dementia. Most of these people are within 3 to 5 years of their diagnosis, so relatively early. But the other thing that we see is they don't look at the facial regions that are conveying those emotions correctly. So there's actually a failure to tune in and attend to the visual information from someone's face that helps to convey these emotions. So it's not just that they're not paying attention, it is that they have difficulty, their brain actually is not tuning into the right information. So one of the ways that we tell people to work around this is communicate with your whole body. This is easy for me. I'm a hand communicator. I'm a whole body communicator. I really meant you're going to have to tell me to stay at the microphone because I move a lot. But it is important that you learn to convey emotions with your facial expressions, with your gestures, with the words that you're using, and that all those are aligned. If you are a care partner of someone with Parkinson's disease, do not become upset if they didn't understand that you were trying to be funny. You may have to actually say, hey, I was making a joke there, right? Not after the conversation's already broken down, but I was joking, I was teasing, right? Because in that moment, it may feel very ambiguous for them. They may not have picked up on all the information. So this is, again, one of those places where it's up to the care partner to support the person with Parkinson's disease. So our take home here is that we have a lot of tools and therapies to support better communication in PD. Not every tool will work in every context, and patience and persistence are key. So I have about 3 minutes left, I think, right? 3 to 5? 3 to maybe 5? 3 to maybe 4.5? Okay. See, I told you, don't do this. My husband's just happy to have an hour break. Okay. All right, so let me tell you a little bit about where we are headed, and I want to share this exciting stuff with you. Where we are headed is trying to take the different things that we've talked about and convert those into tools that can be used for remote assessment and remote therapies. And we do this not only using the traditional tools of microphones and audio recorders, but we've actually been developing new technologies that, and patenting those, that allow us to take peeks into people's behaviors at home and actually provide feedback for things like swallowing changes and speech changes. So I want to share some of those with you. So I'm going to fly through these really quickly. Part of what we've been doing in my lab over the last little while is thinking about how do we use talking, how do we use how people convey stories or read paragraphs to be an early predictor of dementia or cognitive changes in Parkinson's disease. I have to tell you, I'm not interested in diagnosing Parkinson's disease. My colleagues do a fantastic job of that. The neurologists I work with are experts. They don't need my help. But finding cognitive impairment is harder, and Parkinson's disease. And so we have been doing these studies looking at how people tell stories and how they read paragraphs. And one of the things that we've been able to do is actually come up with methods for finding early Parkinson's disease, dementia, and people who are at risk of developing Parkinson's disease, dementia, with about 80% accuracy. And that's not bad, actually. So we've done this through a series of phase 2 and phase 3 trials. When we get to a phase 3 trial, it means we take a whole bunch of people with Parkinson's disease. We have no idea whether they have cognitive impairment or not, or are going to develop it. We blind ourselves to it. We collect their samples, and we try to predict who's going to develop that. And we follow them over time. And when we did that, we were able to find the people at greatest risk with about 80% accuracy, just with the simple 2.5-minute, 3-minute speech task. Not terribly bad. More work to do, but not terribly bad. So my first pitch for a study then is we're still doing this work. We can do it completely remotely. We can collect it from your home. If you're interested in helping us, please do. We need about 50 more subjects, 50 more participants for this. We can see you no matter where you are. But then the exciting thing I want to share with you, and I promise 2 minutes, I promise. We have invented this device. We've been working about 8 years with this with engineers in the Rogers Research Group at Northwestern University. The forever problem for me as a speech therapist is there was no way to follow my patients outside of the clinic. It just didn't exist. And so we have developed this little tiny wearable sensor. It's about the size of a Band-Aid. You fit it right at the top of your chest. It measures what are kind of movement behaviors in terms of airflow and skin change and conductance that happens underneath the skin. You can wear it in the shower. You can do everything but go deep sea diving in it. You can sleep in it. We can measure heart rate, swallowing behavior, speech behaviors, blood pressure changes if we add an additional sensor at the ankle, sleep behaviors, everything using this single sensor. This has started to revolutionize what we can do. So we can actually get the signals in and separate them into talking behavior, breathing behavior. So now what we're doing is starting to move toward using these sensors in swallowing therapy because we can check the strength of swallowing. My colleague, Dr. Martin Harris, is doing this work. If the swallow is too weak, it provides a vibration to tell you to swallow more strongly. We're starting to use this in the context of speech work, where if the speech gets too quiet, we can prompt you with a vibration. What we're also doing with this behavior is starting to look at aging and neurodegeneration in this more global way. So we're trying to understand what separates out people who get Parkinson's disease from people who age exceptionally from people who age typically. And so we have this new study that I'm overjoyed. You're the first people to kind of know about it. We just received a $20 million grant in US dollars from the National Institutes of Health. We will be building a center in aging here in Canada as well as in 4 other sites in the US to actually have people wear these sensors over a multiple-day trial. And we're looking at what separates out people who age exceptionally, meaning those who are 100 years old but cognitively are like 40-year-olds, from those who age typically, people like me. We're also doing this work in our Andre study. So some of you may be familiar with Andre. We have a new study called Hands Ontario. So right here in Ontario, where we're looking at people who have Parkinson's disease, Alzheimer's dementia, aging, typically aging. We're recruiting for that study now, where you would wear the sensor at home, give a blood sample, do a little bit of remote cognitive testing. Again, all of this, none of this requires an in-person visit. It's all done virtually. And what we're hoping to do with that study is now combine that with our super aging grant that we just got to really look at what are the behaviors that define aging across the spectrum. So from typically aging to exceptional aging to people with Parkinson's disease, the goal being, how can we push, how can we understand what's happening in aging so we can aid some of the things in Parkinson's disease, right? And then lastly, I'll share with you the study that we'll be starting up in the next little bit. This is work that's done with myself, Bill McElroy, Dr. Van Uddingham, who I know has spoken with you before, so Karen and I do a lot of this work together, Tony Lang in Toronto. And so this is a new study that we're getting ready to launch that is linked to the Hands Ontario study, where we'll be using this sensor data to look at conducting a levodopa challenge test in your home. So currently people go into the clinic, they're there all day. And we'll be looking at kind of this variability in response to taking medications and everything from tremor behavior to bradykinesia behavior to speech behavior. For the first time, we're going to be able to look at speech in this context. Because again, we've never had technology to be able to do that, now we do. So a couple of really exciting studies that are coming your way. I hope that you might give us a try. There's at least 3 of those that I'd love for you to think about. And thank you for indulging me to go over 5 minutes. I really appreciate it. So thanks for your time. It was lovely being with you.